I'll be talking again about my experiences at the Western Blind Rehab Center. Again, we're the only VA that has both a polytrauma center and a blind center. And in the case study that I talked about yesterday, I talked about the patient who said, well, why am I going to blind rehab when I can see? You know, he was 20/20. So I think for us, we realized that there was definitely staff training that needed to happen within Western Blind among mobility, low vision staff, working with occupational therapy, physical therapy, speech language pathology, neuropsychology, and on and on and on, optometry. So it's a lot of work to do, and it's been a long road since we formally established the program. I do want to say that we do courtesy reviews for anybody that you might want to refer to the program, where we look at their case, get some information. Usually what we'll do is we'll do pre-screening, we'll talk with the veteran or the active duty service member, we'll talk with the family, find out what the issues are. If you're already treating with them, you're already part of the treatment program, so we would pull you in. The other thing that we've done kind of as a bridge for some of the other programs out there is if we do have somebody that comes in, if at your program you have an OT, a O&M, a low vision therapist, we have brought them into the program for a week or 2 weeks while the patient is there so that when they go back, there's some follow-up training. So we do provide that additional training, and we're also a CE accreditation provider for O&M, CLVTs, and rehab teachers. So just a little plug, and I have some information if anybody wants it. So that's mainly just a little review from yesterday. Also, today, again, we're starting to talk about stroke, which is also a huge population that we serve at the Western Blind Rehab Center through CMBR. Stroke is also a huge population where we see these hemifield loss, all these other vision dysfunctions. So we talk a lot about TBI and the numbers within TBI, and there's a huge population of veterans with stroke. So that's also kind of an untouched and another group of veterans that really need services. Does anybody know the little story about 4 people? Named everybody, somebody, anybody, and nobody? Has anybody heard this? Okay. I heard this once and it stuck with me. So I think it's really telling for case management and probably in wherever you work, whatever you ever done professionally, I'm sure this story will stick with you. So this is a story about 4 people, everybody, somebody, anybody, and nobody. There was an important job to be done, and everybody was asked to do it. Anybody could have done it, but nobody did it. Somebody got angry about that because it was everybody's job. Everybody thought anybody could do it. But nobody realized that everybody wouldn't do it. It ended up that everybody blamed somebody when nobody did what anybody could have done. So I heard that once and it always stuck with me. And really, for case management, going between VA and DOD, that really stuck with me. So trying to manage and coordinate all the different case managers. We have OIF, OEF, OND coordinators. We have VBA case managers. We have caregiver coordinators. We have the Vision Impairment Service Team, or VIS coordinators, Federal Recovery Care coordinators, military case managers, military liaisons, benefit counselors, social workers. And then I ran out of the slide, so there's more and more case managers, there's more and more people involved. And the thing with this is some of these people haven't even met the veteran. They don't have a rapport. It's a piece of name on a paper for some people. Although I'm not saying that's how they treat them, they just haven't met the person, they don't have that rapport. So we really saw a need to have a coordinator, and that's really what the CMVR coordinator position was to do, is to be the point of contact among all of these people. Be the first point of contact with the military, for the patient, the active duty service member, and then coordinate services. And all of these case managers follow the active duty service member or the veteran through their transition and coordination of care. So it's really important that all these people are informed, they know what's going on. So we talked a lot yesterday and today about the importance of rapport, especially for these combat injuries and active duty service members that are coming back with brain injury. Rapport is really huge, so if you can take that time to develop that rapport, you'll get a lot more out of rehab, you'll get a lot more out of treatment. You'll find out a lot more what the issues are rather than hitting their wall, because the wall does go up. We have to remember that PTSD, post-traumatic stress disorder, it's a disorder, it's an anxiety disorder. So your first introduction, your first time you meet somebody, that's really a lasting impression. If you have 15 minutes to meet them and quickly rush them in and quickly rush them out, they're going to remember that. That's going to be a negative experience. They're more likely not going to want to come back. They're more likely going to keep that negative experience in their mind, and they'll probably talk about it to other people. What we try to do, since we know that that first introduction is really important, we try to do what we call a personal handoff or transition. So when somebody's in the polytrauma ward, as a coordinator, I would usually go over to the polytrauma ward, meet the patient, meet the family, start building rapport with them so that we could kind of ease into the transition. Once they come over to the Western Blind Rehab Center, then we also would meet with psychology together as a team. We meet with social work as a team to kind of hand off the care that this person is part of your treatment team. These are things that they might work with you on. So psychology, for example, psychology is a supportive role in inpatient rehab. They're there to help them get through basically the rehab process, deal with the adjustment issues, deal with the emotional changes they might be going through. Remember, our brains control our emotions. So a lot of times these patients are very emotional, and they may not understand why they're so emotional. So that personal handoff is very important. This also works when we have somebody going from our center to home, or they're going to, maybe we're referring them for bros or another provider back at home. So we try to make that bridge as well, whether it's a phone call or a VTEL call, so that the patient gets a sense who this person is, what their name is, what they look like, what they sound like, so that there's some kind of bridge. So we use that a lot, and we find it very effective in the treatment. Another big thing is discussing expectations. Discussing expectations with the patient, their family. What are their expectations? Sometimes their expectation might be, I want to be the same person I was before, or I want to see exactly like I was before. And realistically, we have to tell them what the reality is. When we're teaching scanning strategies for field loss, we're very clear with them that we're not expanding your field. We're not making you see more. We're teaching you to use your vision more efficiently and more effectively. So expectations are really an important discussion to have, and that's kind of an ongoing discussion, especially as we're trying different therapies and we're trying to fine-tune certain things. What works for one person with a brain injury, well, no, doesn't work for the next person that comes through your door with a brain injury. So being upfront about those expectations, and a lot of in our pre-screening, that's a lot of what we're talking about, what the family should expect. How will they be involved in this process? What will follow-up be like? Those types of things. Feedback is also very important, both feedback from the patient to us and us to the patient. How did a certain session go? Giving them feedback about their performance. and asking them, how are things going in your program? How is training going with OT or PT? How are they perceiving it, or how are they, what is their experience? And sometimes you'll find the issues or how they might be perceiving certain things that maybe aren't what the instructor intended or what the therapist intended, but there might be a roadblock there. And so it opens up a lot of discussion. It opens up some communication. We talked about communication this morning. Communication is key. Effective team communication is vital, and we all communicate in different ways. There's a different rehab language. There's a different medical language. When you're in polytrauma, there's a different language that we all need to kind of learn each other's language. And a big thing that we use are recommendations from speech pathology, from neuropsychology, really from all the different assessments that are done throughout the hospital, and make sure all the team members know what's going on. We have a lot of team meetings. We talk a lot about the cases that we're actively involved in, and cases that we know are coming up, and cases that we're following up on. So when you're case managing, it's just not who you have in front of you, it's all those other people that you've been working with and that are going to be coming through the door. So in some sense, we're all a case manager when you have the patient in front of you. The other thing that early on was really important was coordinating these visual training goals into other treatment areas. As I mentioned, going to physical therapy, going to occupational therapy, different types of therapy with the patient. I remember one session in physical therapy, they were doing some work on the parallel bars, working on balance. And I said, well, what we're trying to achieve with the vision is opening up this left field. So we're incorporating a head turn. So while they're working on the balance, the parallel bars for balance, let's incorporate a head turn. So showing PT some of the visual training strategies that you can use simply with my favorite tool, just some Post-it notes. Putting some letters, numbers on Post-it notes, put them on the wall, on a board, and have them do some head turning. How does that affect their balance? How does that affect the training that they're trying to do? What is the range of motion in the neck? Is that appropriate for them to turn that far? So those are conversations that need to happen, definitely in the assessment process and in the treatment process. And I think that's something that we're often working in separate areas, and again, we need to communicate and work on those goals together. You also need to communicate with the patient and educate them. I talked about that yesterday, about their deficits and the recommendations. We do a lot of education, as I talked about yesterday. We also do an exit interview with the patient and their family, and a lot of things that come up in that exit interview is, well, this is the first time that someone actually told me about my brain injury or talked to me about what that means. And I know it's not the first time that it happened, but it's the first time that it was accessible to them, that they actually understood and they started to develop a language for what that meant. So that's also a really important part of this process. And really that can come from all of us, but we need to make sure that message is the same. As part of case management for, and this is more unique to our program, but we provide the accessible patient schedule for therapy, for recreation, for leisure. So we're making sure that the patient can follow their schedule, they can access it either printed or if it's audio, whatever method they need. If we're working on an iPad or an iPhone, you might schedule put their schedule in their calendar, set it with alarms so that they can start getting some control, start getting getting used to using this tool to help them with their memory issues. A lot of times there's behavior issues with brain injuries, so we're also assisting with those. With those might mean going to a certain session with the patient as a case manager or coordinator, so that when you see the patient and there's one of those behaviors, you can kind of get more out of that, or you can learn about what those behaviors are. You may not have a lot of time to kind of go on the record and go through all the psych notes and learn about all the things that are the issues with the behaviors. So it's been really helpful to have that kind of in-between person, that point of contact, to help and assist with those behaviors. A lot of case management is being a translator for the family, being a translator for the patient, being a translator among the team. There's a lot of things that are, I guess, misperceived by the patient as they get feedback. If it's a lot of feedback coming at them, a lot of times they tend to shut down. If they go to an appointment and they went alone, and I say, well, what did they say? What did the doctor say? What did the therapist tell you? Oh, I don't know. She said, I don't know. I didn't like the way she talked to me, or the message isn't received. So really finding out what the message is and how to communicate with this person is really important. What types of things might trigger them, or what types of things might help with their understanding is very important. So as a case manager, a lot of times we're translating. We're in this role. We're also doing a lot of training with our staff at our center. Usually every staff is a patient coordinator, which means they're the point of contact for that patient. So any issues, and these tend to be kind of generally smaller issues like, oh, my room is too cold, I need padding for my bed, I need extra pillows, things like that. The patient coordinators are taken care of, and then with the CMVR coordinator, we can kind of deal with the major global issues that are happening that require more time and management. As a coordinator, I'm not necessarily scheduled with somebody every day, so I do look to those patient coordinators to let me know how's it going, what are the issues, and then setting time aside to meet with the patient and say, okay, well, let's do a little review of how everything's going. So as a coordinator, when someone first comes in, I'm really busy. Once they're kind of settled into their program, their treatment team's set up, they're having a pretty good program. They feel comfortable with their instructors and their treatment. They kind of flow along and go through the process. And then again, at transition time, at discharge, coordination becomes huge again. Another big thing for communication is the communication between the military case managers and the VA case managers. Again, these are two systems that require a lot of involvement to make things go smoothly. To make sure TRICARE, if someone's active duty, we need TRICARE authorization. Does anybody deal with TRICARE? You do?
Communication and advocacy. Because we were doing something outside the box, I did lots and lots of letter writing, fighting for services for the soldiers.
Yep.
So yeah, they're fun to work with.
Yep. Yep, that's a good way to put it. TRICARE is a lot of fun. And advocacy is huge. So if somebody is active duty, they're under military orders to be at our facility. Their job is to be there. Their family members can also be under military orders. Sometimes the military thinks that a family shouldn't be there, that it's not necessary that a family member be under orders to participate in the rehab. And then it's up to us to write the letters, advocate for the family member, advocate for the active duty service member to have somebody with them to make sure that they're going to have all the support that they need. Advocacy is also a big thing that we work on, especially with active duty service members, to let them know and to actually show them how to advocate for themselves. what types of things do they need to advocate for? They're used to mostly following orders. So it's a big shift to them. I think this morning you talked about they're taught not to complain. It's a weakness to complain. So we have to spend time with them and talk to them about it's actually a strength to bring these issues up. These are difficult issues. It takes a lot of strength to face these issues, and to try to get that from them is going to go a lot more when they get out, when they're working with other providers, if they can advocate for their needs, if they can say, if they go into a therapy session with somebody, and they're sitting down and there's a bright window behind them and the shades are up and the sun's coming in their eyes, some people will sit through that. They'll sit through the pain, they won't say, can you put your shades down? Can I move my chair? Those are things that they need to know that it's okay for them to do, to request, to let a provider know that that's what they need. What to expect post-discharge, this should really be from the military, that's on the top of their minds. What's going to happen to me next? I don't know. So as a case manager, I'm trying to communicate with their military liaison, their military case managers. Where's this person going to live? Usually what happens is someone goes through a warrior transition unit, a WTU, and usually they go through their MEB, their board in that time, and that can be anywhere from 6 months to a year. I've heard of some people being in their warrior transition unit for 3-4 years. What that means is they're housed usually on a military base somewhere that's usually not necessarily near their home or near caregivers and family. And what we try to do in the rehab process is prepare them for the next step. Well, where are you going to be living? If I'm going to be teaching you to take public transportation, are you going somewhere that has public transportation? Is that a realistic goal to work on? Are there quarters where you can actually do some independent cooking? If you're going to be there for a year and you're getting this training, the training should really prepare you for what the next step is. So with military, sometimes it's unknown what that next step is. Sometimes we're told, well, okay, they're going to go to San Diego, so we prepare them for San Diego, and then at the last minute, it's changed to another location. So this is difficult for us in the rehab process, but it's even harder for the patient. They don't know what to expect. And in some sense, what we're doing in the rehab process and what's going on in the military is a separate conversation. And I've had a lot of our teams are large teams with many of all those case managers. You saw the list of many of them participate in our team meetings. And sometimes these things come up, and sometimes it's an unclear message. So really kind of keeping in contact with the military case managers, letting them know the importance of, of knowing, well, we need to know whether there's stairs present. Are they going to be on the 3rd floor, the 4th floor? Are they on the 1st floor? Are there elevators in the building? What is the design? Is it accessible for them? What is around there? Can they get additional occupational therapy, physical therapy, speech if they need it beyond the training? So there's a lot of planning in that. Sometimes the military liaison, sometimes some of the military case managers are also military that are also going through the discharge process. Some of them also have PTSD. So you might not get your phone calls returned. You might have to really reach out and keep calling these people to find out answers, or to even find out who those people are. When you get an active duty service member, usually it has to come from them. Who's your case manager? I don't know, Nancy something, she talked to me once. Would you have their phone number? No. Well, who else is involved in your care? So they don't arrive with a piece of paper that says, these are my case managers, these are the contact information, these are the people that need to be involved. So again, the military is a whole nother system of care to incorporate and to communicate with. And then, of course, whether you're dealing with the Army, the Air Force, Marines, everyone's a little bit different how they do things and what their process is and what their communication style is. So it's really important to, what I do is, as soon as I have somebody's name, I know they're coming in active duty, I start going to the military liaisons, getting names, getting contact information, sending out emails, sending out phone calls, and with communication, we all communicate differently. Some people like to respond by email, some people like text messages, some people like a phone call. So I do all of those things. I over-communicate. But that's the only way to get everybody together and on the same page and understand what we're trying to do, because we really are all trying to do, provide the best care that we can provide. And we have so many resources, but again, it's how do we get all these resources together? How do we coordinate these resources? A big thing is the timing of injury and, of course, the severity of injury. If somebody is injured in combat, they've gone from combat to a hospital. There's no transition for them. They might be in a hospital for many months. So from the battlefield to a hospital, they may not have been home. We talked about that yesterday in my case study. They may not know what it means to live with whatever vision they have. They may not know what this really means for their life, the functional implications. We also serve patients that may have had a stroke or may have been living with their brain injury or their vision dysfunction for a long time. So they might already have some strategies that they've incorporated. They might be more comfortable with or more along their adjustment process. So timing of injury is very important and also a consideration when we're looking at case management and coordination. So just another thing to consider. Community reintegration is really big. That's huge, especially for the guys and female active duty members that are coming from the battlefield into the polytrauma transition program and then to our program. This is usually the first time that they're going back out into the community. And this is really where you start to see the PTSD. You start to see the reactions. When we're doing mobility with these people, we're taking them out into the community. We're taking them out. We go downtown Palo Alto. We go to Stanford University. We're trying to navigate these complex environments, teach them the skills that they would need to do this independently. And we're seeing how they react to that. And trying to also give them the strategies for how to recognize their triggers and how to deal with their triggers. But we're not usually doing PTSD treatment and blind rehab or vision rehab treatment at the same time. We're trying to give them resources to more fully get engaged with their PTSD treatment if that's needed. As I mentioned, there's a lot of resources for recreation, there's vocational resources, so trying to get them in contact at the proper time. So voc rehab may not be appropriate for somebody that's fairly still acute in their rehab process. So the timing of those resources are important. There's also a lot of outside VA resources that you can get in touch with. The case study that I presented yesterday, we referred him to a program. It's called the Wounded Warrior Project, where he went to, I think was in Florida, and he went for a year, and it's a retraining program. He learns study skills, he goes to classes, he learns how to take notes, and it's all done with other veterans, so there's that peer support. They're in it together. And although it was a difficult process, he was able to complete that 1 year, which really set him up for being able to realistically live independently, deal with some of the struggles with going back to school, dealing with PTSD, learning how to communicate with teachers, and being in a group setting. And he's actually enrolled in school now for computer science. So that program really helped out. So there's a lot of different hidden programs out there, lots of resources, and new things pop up all the time. So trying to keep in touch with what's available. And I always ask social workers and the other coordinators, well, what are the resources you use in your area? What are your hidden resources that are really good? And I try to keep some lists of those. Another important thing is establishing goals. We could talk about this as rehab goals, but really establishing goals, if we think of life goals, what are your life goals? To go back to school. A lot of times when school is a goal, because a lot of times these people are young still, we recommend that they don't go back to school and get a full caseload. Maybe start with one class, see how that goes, use some strategies, use their tools, so that they don't get overloaded right away, so they have a positive experience, and then that will encourage them to continue along that path. So establishing new goals. Also with the timing of injury, nobody ever prepared, or nobody ever thought that they would have a vision problem. Nobody ever expected that they'd be in a polytrauma center or a blind center. So it's never good timing to have that happen to you. And whatever goals they had prior to that might change. So that's important to understand, that suddenly their life goals may no longer be there. They may not have goals at that point. And they may not have even considered what's the next step for them. As a case manager, coordinator, the caregiver and family involvement and training is also huge. We do have Fisher House at the Palo Alto VA. We also have a Defender's Lodge that they're building, which is similar to a Fisher House. It's a lot bigger, more rooms, so that family can come and stay. And it's a really nice environment. It's more of a home environment. There's kitchens for them to use, and there's other family members, so there's support there. We do provide counseling during this time of transition and change. It's a time of transition and change for the active duty person or the veteran. It's also a time of change for their caregiver or their family members. We talked about the family expectations regarding rehab goals, involvement, but also how they should be participating, or how we would want them to participate on mobility. A lot of times we want family to come, but we'll have to let them know for safety, and for our, if we're doing some street crossing work and the family wants to be there, we have to really let them know where they need to be, so that as we're in our positions, that for safety, that they're not in the way if we need to stop them for something, if they don't see a car coming. So really letting the family know and having a open dialogue about their participation. And a lot of times what we recommend is that they participate heavily in the beginning. That can also be a good bridge for that rapport building, incorporating the family. And then we try to kind of taper off some of that family involvement, which is appropriate sometimes, and then sometimes it's not. That's where really getting to know the family and some of those issues help. And then again, towards the end, towards that discharge process, getting them involved again so that they understand how these tools should be used or what kind of things they might need to help them with. Connecting them or introducing them to caregiver coordinators. There are coordinators now in the VA that are mainly there for support for caregivers. A lot of VAs have a caregiver coordinator, so finding out who that is and connecting families. There can be resources for travel, resources for food, lodging, those sorts of things if your VA doesn't have a Fisher House or those other resources. And there's also a lot of service organizations that can provide clothing and funding, transportation, getting them set up with paratransit services or housing needs. We had a veteran come to us. He was an OAF veteran that lived in Hawaii, and he came to Palo Alto with just a pair of shorts and flip-flops, because that's what you wear in Hawaii. But in Palo Alto, it's cold in the morning, and it's usually cold at night. And he didn't have the money to go and buy a whole wardrobe, and he didn't have anybody to send him more shorts. But he needed some warm clothing. He needed shoes for mobility. He needed socks. He needed everything. So plugging him in with service organizations, plugging him in with the different resources at the VA to get those things so that we could actually do training. Another big thing is changes to the home environment for accessibility. Remember, if these people haven't been home yet, they don't know necessarily what their needs are. Do they need grab bars in the bathroom? Do they need a shower chair? Do they need ramps installed? And there are different HISA grants and different things they can apply for to help them get funding for these types of things. So plugging them in with those is really important. Discharge planning and transition to care. Discharge planning for us, since we're inpatient, is transitioning from an inpatient to an outpatient. And so we do, as I mentioned, a lot of communication with the outpatient rehab team. And again, we try to make that connection, include that provider in the team meetings, so the patient or the veteran knows who those people are, kind of what the plan is, who they'll be seeing, and having their contact information too. I'm sure, as you know, if you deal with a lot of outpatients, that they miss their appointments, there are a lot of cancellations. So we know those are due to a variety of reasons, but again, that rapport and trying to do that handoff transition has been very successful. And making sure any follow-up recommendations go to the appropriate people so that they're actually followed up on. It's not just a list of things in a note in CPRS, but they're actually done. So change is difficult. Any type of change is difficult. These are people in transition, families in transition. Again, it's not something they probably ever considered that they would need or be in this predicament. So having some empathy about that and really trying to understand what they're going through. We have cases where there's families, there's children involved, there's young children. How are they going to relate to their children? How are they going to relate to the family? So we try to incorporate the family again as much as possible. But it is a change for all of them. With brain injury, there could be personality changes, and caregivers really struggle with that a lot. Sometimes there's not a caregiver. That's even a harder predicament to be in if someone needs that additional support. So it requires a lot of patience. adjustment to vision loss, adjustment to disabilities, adjustment to physical, the change in maybe physical appearance. All of these things are things that our patients go through, whether they talk about it or not, and we try to encourage them to talk about it because it's on their minds. And letting them know that what the process is for adjustment, and it's different for everybody, kind of what to expect through that process is important. And that if they are being emotional, if they are having a hard time, letting them know that is okay. That's the process that they are going through, and trying to provide them with some tools and strategies to deal with those. Another great thing about an inpatient rehab setting is they're there with other people that are going through that process and other people that have gone through that process. So it is very therapeutic for them just to be among their peers and see, well, hey, that guy can do it. He's a lot worse off than I am. I can do it. So just them being there and having that camaraderie and being together is very therapeutic. Another thing that's really important is to think about is a loss of identity. Somebody that is a Marine is a Marine. And when they're injured, they feel like they're not a Marine anymore, and they know they might potentially be discharged from the Marines. So that's a huge loss to them. And a lot of times they might not even have the language to discuss that. But it comes out in certain things that they say or certain questions that they ask. They want to know what that discharge process is going to be. And again, that's something I can't provide to them if it's not being accurately communicated to me. So that's a difficult thing for them. Also think of identity. Think of as a family, what are your roles in the family? Those might be changing. So there's a lot of loss of identity. There's a lot of loss of control here. I talked about the personality changes and just the stages of grief and adjustment. So quickly for this, I have a box here. How many squares do you see? 16? 17? How about 18, 19, 20? So we all see something different. So we must consider perspective. Perception is big in our patients, how they're perceiving something. We want to know how they're perceiving something. And really, we're dealing with the whole person. We're dealing with the whole of its parts. We really have to think holistically. And the more we look, the more we see the complexity, the more we see how things fit together. And really, that's what case management coordination is looking at the whole of its parts and fitting them together. So I think it's great that we're coming together, and it's great that we have in our packets the recommendations for really what to do, some guidelines, and I think that's really the start of getting some of this treatment and some of this rehab to these patients that feel like there's no treatment for me, or there's no place for me to go, or I don't fit in anywhere. So that's my bit on case management. And I'll open it up for any questions or discussion.
Thank you for a very insightful and thorough consideration of this. We often forget about this part of it when we're talking about the clinical things. And this is as much a part of the clinical aspect as anything else. I want to comment that you're working in a system that has a location and a certain reach.
Right.
But these problems are happening on even a more global basis. I mean, what happens when a person that you've been taking care of, and you've established all these relationships with, and you've got this capability, and then they move to, Virginia or something. And so one of the things that we've been working with at the VCE is trying to establish mechanisms for that. And I introduced Joanne Egan earlier, and she's constantly getting these things because she participates in this worldwide visual trauma VTC that Dr. Mazzoli puts on once a month, and they're looking at the people right at the time of injury and how they get evacuated and how. But it's all about handoff. It's all about communication of information between providers. It's all about dealing with these things at the earliest stages. But then beyond that, we get issues that happen. I mean, the most interesting one for me was Joanne called me a couple of weeks ago, and she said that with all the hype and public relations about TBI and the fact that we had this emphasis on trying to take care of it, that there was a veteran from World War II. How old was he? 90, yeah. And that he had the TBI events in World War II, and he had these vision issues all these years, and he's been telling people about it, and nobody's paid any attention to him. And so he contacted the VCE and wanted to, get worked up for it, because, I mean, I don't know what his issues are, but I think, he is one of these people who's seeking validation for that the system has never paid attention to all these years. And so we got him hooked up with somebody that's a TBI optometrist in his area, and we're going to look at that and see what happens with that. But it goes beyond some of the issues that just the traditional issues. Joanne has been busy with patients that come from other countries. We have one patient in particular that's not a U.S. veteran, but is a veteran of the Georgian Army and who was blinded in Afghanistan? Yeah. And so he's been out at Madigan now for a year, getting reconstructive surgery, and then working with the people at American Lake to try and get his blind rehab done. And so if you think it's complex dealing between just DOD and VA or within departments of VA, then try to bring in a foreign government and all the issues that go with that. So these are very important problems and issues. Good, you're going to get up and talk.
I want to thank you. I want to say to you, you are not alone. This is happening globally, across the country. And I don't know, are you familiar with the Lead Coordinator Program, which is people in the national capital area who set policy have realized that there is an overabundance of resources, case management of all those people and more that you listed.
Right.
And when you ask a service member or veteran who's your case manager, or I don't know. If you ask a military member, if you can't get case management out of them, if you say, who's your platoon sergeant, they know that answer.
Right.
And right away. So, and the platoon sergeant, by the way, will know who the case manager is. But, the Lead Coordinator Program is a DoD-VA joint program where they've recognized that sometimes people don't know who's driving the train. So it's both I have to look at my notes. It's both an inpatient and outpatient program where someone who is already a member of the care team is designated as the driver. And that is the name that soldier or veteran should know. And that is the person that other members of the team should know to contact or know to know what's going on or have a resource to ask a question. On the inpatient side, that will be more of a medical case management driver. And on the outpatient side, it's going to be covered by the recovery care coordinators, so more non-medical. And that's not to say that people who are outpatient don't have complex medical needs. It just depends on where you are. I particularly want to comment on your translation services because my background is military case management as a civilian. And now I go back to my colleagues and I say, you know, I'm in a little office that's located in the ophthalmology clinic. This is what I'm trying to do. And what I try to do is, you know, sometimes when I look at the squares, they're not all there. Or a little square might be outside the box. And so what I try to do without carrying a caseload and seeing patients every day is try to bring the squares in alignment so that pieces come together. So I always say, and this is for all you providers in the room, other people may occasionally read your notes. And they will require a degree in cryptology to understand what you are saying. And it frightens them, and they're most likely, if they're going to read a note, they're most likely reading one they can understand where they get the point. So what I ask of you, I offer translation services for them. I say, you know, I offer translation services. And they look at me and I say, well, do you ever try to read an ophthalmology note? And they're like, well, not really, because I can't. And I'm like, well, here's my number, give me a call. And they do. And I offer translation for those notes and for those words to the service members and veterans as well. But so what I ask you to do is please give us a clue, you know, on the AP. Just say it, one line in English, one line. And then if they have a question, they'll call you. But most likely, if they see symbols and things they don't understand, they're not going to read very much. And remember that as much as we try to work together, the military, the DoD system, and the VA system are different. And when there is a soldier who's receiving care in the military medical system, he is number one. He or she is number one. That is what the system is there for. When dollars get tight, when things get crunched down, over 65 is going to go, elective is going to go. Active duty military, the hospital has to pay to send them. They are going to be retained within that system as much as possible. They're number one. There are access standards. For a wounded warrior, there are more stringent access standards, and that's what they're used to. So when they get through their now year-long process of the integrated disability evaluation system, which is joint, DoD and VA, and they get out into the VA system or get out into the civilian system using whatever mechanism of insurance they have, TRICARE or whatever, that system wasn't built exactly for them. It was built for everybody who needs the health care. So that's a big adjustment for them. So, and the other point about the wounded warriors who've come through and I can speak about the Army warrior transition system. It's built with a platoon sergeant and a case manager, and they make sure that they go to their appointments. And they are held accountable for the soldier going or not going to the appointments. And I have mixed feelings about that, because while we do a great job of getting them where they need to be, when they're in the military, when they come out to the VA, is somebody calling them saying, you have an appointment, you missed an appointment, you need an appointment, where are you? Because they're more or less accountable for seeking their health care, and they're not used to that. So it's a problem. We know it's a problem. And there's no easy solution. It's a joint system. They lose their identity. sometimes their career plan was to stay in the military. And when they're in the military with a job description with an MOS that they're an 11 Bravo, an infantryman, or something like that, they can stay in the military with that job description and with those skills. But even a fully sighted, fully capable person who gets out of the military has difficulty learning how to translate those skills into a civilian workforce. So if you have any type of, visual problem or post-traumatic stress or anything, that makes it even more difficult to translate to find the skills that you have and to translate them into the civilian workforce. So that's what I have to say. I want to say thank you.
Thank you.
Thank you.
Yeah.
And I'm at Madigan, and you can call me.
Okay, I'll make sure I get your contact.
Because if they're active duty Army,
Yeah.
and they are at Palo Alto, they belong to Fort Lewis, and that's us.
There was a sort of emblematic case of lack of coordination that she was instrumental in solving. There was a guy that came over who had, he was losing his vision from, what was his condition? The one that...
NMO.
Right, it wasn't a combat injury, but he was losing his vision neurologically, and he was becoming very rapidly, effectively blind, but he was otherwise healthy, and he shows up at Madigan, and he was up in the neurology clinic, and he was facing the fact that he was going to be blind, but they were just putting off any assessment of anything to do with that while they were treating him medically. And the plan would have been that after he was cared for neurologically and he was finally squared away that way, then they would eventually ship him to Palo Alto for his blind rehab. But that could take months. In the meantime, this guy is going crazy in the hospital. And Joanne says, she goes around and she snoops for people, and tries to find them. And she discovered this, and she said, well, don't you realize that there's a blind rehab center about 3 miles away at American Lake, and he could go over there as a patient and actually live over there because he has no medical issues that would prevent that. I mean, he's not bedridden or anything like that. And so they got him over there, and they got him involved with early blind rehab, which helped him a great deal as an individual. But it was a breakdown in the way the system's structured that the care coordinator, who was, reaching across all these disciplines, was able to do something about. And I think that we all can do those things in our roles if we just open our eyes and realize it.
And to just make a couple comments, one is he was a 25-year-old active duty soldier who was confined to the bed on the hospital ward because he was a falls risk and he couldn't see. And on a normal, regular nursing floor, we don't have people who can be there 24/7 to help, to get him to the bathroom, to make sure he can eat. And I said, American Lake is across the freeway. And they said, well, he'd have to go to Palo Alto. And I said, well, not necessarily. So I worked with the inpatient military case manager, and we got in touch with Tim Sniffen, who was then the director of the blind rehab at American Lake. And Tim and Irene Yang and Don Feldhaus and Walt Rakoven, the VIST coordinator, came to the bedside the next day, and Don started immediately to kind of do an evaluation with him and give him more than the pair of moccasins that they had given him to sew up while he was sitting in the bed. So Don brought over a talking watch and showed him how to set up his food and did all those things that, immediately, and then went back later in the day while we were upstairs filling out the paperwork to get him enrolled, and did his full evaluation, gave him some basic mobility stuff. The next morning, they drove him to American Lake and got him into the program. And even though his vision, came back up, and Irene saw him repeatedly, she's nodding, he got the skills that enabled him to go home with his parents and be safe. What he wanted to do was return to playing games on his computer because he was like a master gamer. And Tim was able to help him get some of that equipment, to get an iPhone, which is what he wanted. Tim put him on the bus, made him go, got him to the iPhone store, made him get the iPhone, helped him with what he needed. And he did in, how long? Just a few weeks. He did what he needed from the program, which is set up that it's not your normal population. He did in a couple of weeks what would normally take an older veteran, 6 weeks to do, and was able to go home with his parents and receive care in the community. So, like I said, we're two different systems. The military doesn't have the resources for vision services and rehab services that you all have, and we just need to bring the pieces together. So,
I would say that we're even more than two different systems, that every VA is so unique that really working with other VAs,
and
it's dealing with another system,
right.
even just another VA. So
I'll quote my dear friend
complex.
Felix Barker, who says, when you've seen one VA, you've seen one VA. And then somebody added the other night, and on a different day, you'll see another VA. So,
right. It's true.
So, right. Right. And Dr. Mazzoli's thing is that this soldier was on Lovenox because he was bedridden, because he was a falls risk. And this is common in the military transport, is that, they have criteria. If your rails are up and you're in the bed, you fall into the DVT protocol and you get some form of Lovenox. So it was important to get the 25-year-old out of the bed, more than once a day. So,
Thank you.
thank you.
Anything else from now? Oh, Rob.
Yeah, Rob Mazzoli from VCE. Thank you. I mean, this I see as being just a huge problem that we have, that is not unique to this conflict, but we see it with conflict. And I was fortunate enough to be invited to Tampa to talk. And one of the, in a side comment, I was talking to a Vietnam-era ophthalmologist who was on the receiving end of injuries coming out of theater. And he said one of the things that frustrated him the most was that he would go to bed at night, and in the morning he would wake up and there would be 5 new patients that he had no idea of who they were, what they were, or that they were coming at all. And the second biggest frustration for him was that he would take these 5 patients and then he would do whatever he was going to do, put them on the plane, and they would go back stateside. And that was the end of his knowledge on that patient. And there was no follow-up, there was no continuity. So the lack of coordination, the lack of follow-on communication has, not changed in the 40 years. We don't have we have not made a system change other than finger in the dike kind of thing from the point of injury into the military system. And it has only gotten worse between the military as our population has become much more mobile. People aren't going to be living in their hometown any longer. They're not going to come back and get out of the military and go home. They're going to go where the job is. And so the job may be initially back home, but very quickly it's going to be somewhere else, and it's going to be somewhere else, and it's going to be somewhere else. And that process of communication from not just the military to the VA, but from one VA to the next VA, from the VA to the community-based, is only magnified now as our population has become increasingly migratory, not just while you're in the military and being transferred from post A to post B, but even when you get out. So the communication becomes a protean exceptionally difficult and from point of injury through point of discharge and beyond issue that I think will become a very significant problem that we need to understand, become aware of, and address. The VA has a pretty good system of it, at least once you cross the level into vision impairment. The VIST system is there. One of the magnifying and compounding problems that I see is what do you do when you don't meet that standard? And that, again, speaks to the spectrum of vision injuries and ocular disease that we see now. Because, yeah, if you're in the polytrauma system, you have unfortunately met a threshold that gets you into the polytrauma system. And we have started to address some of those issues. But there is there's the majority of the people, the 2 million deployments that we have seen across the 10 years, the majority of those service members are not, fortunately, in the polytrauma. We've only had 60,000 injuries or so across 2 million deployments in the 10 years. So far and away, the majority of the people that may have had 100 blasts do not qualify to be in this very robust coordination system.
I would argue, though, and I think BVA and the meeting going on in the other room would argue that they do qualify. As long as you have a vision dysfunction, you should be pulled into the system.
No argument.
Right.
No
Right.
argument. I think that's.
That is correct. Yeah.
And that is but that's one of the issues is that
But it's a gap.
this exists,
Right.
but it doesn't exist here where the majority of the people are.
Right.
And even within the military system, we saw the map of the victors and the visors and the bros.
Right.
But there's unfortunately not a lot of overlap of where those locations are and where the major military posts are.
Right.
And so at one point, that guy with the 100 blasts was not in the VA system. He was still a platoon sergeant at Fort Hood or Camp Lejeune or some other place, still doing his military job, still going to school off duty, still having the vision problems, but not necessarily having immediate access, local access to Houston, to vision rehab. And so even that coordination becomes significant because these resources aren't necessarily located at the military location. Not to say that every military location has to duplicate that capability, but if you're in the proximity, how do you coordinate the transfer between the active duty post and the most local, the most regionally accessible Victor's Visor Bros vision therapy program? So coordination becomes, I think, a huge elephant in the room that really puts is the glue that holds all of our efforts together.
You said, Rob, you mentioned the mobility aspect of the veterans and stuff, and I know that personally because my daughter's a OIF veteran, and I mean she's been to VA hospitals across the country, 5 or 6, all East Coast, West Coast, Middle America, but depending on how much she's migrated around since she got out. So I mean I just know that personally, but you made the point that when a person comes in, if the initial interaction is the one that turns them off so they don't come back. And so then if you're dealing with a system where you don't have good coordination, where there's good handoffs happening, I mean, it's a recipe for disaster because, these people are coming in new to the system and there's not that good coordination and they may not get that initial good feeling about what they're doing, and then they'll fall off the plate again. So it's a huge issue.